Dr. Namle? Dr. Namle, can you hear me?
Sir, yes, sir. We can start 1 minute, sir. 1 minute.
Yeah, no problem.
Yes, sir. Good evening, everybody, to the today's lockdown lectures. And today we have our guest, Dr. Sriram Gopal, who is an alumni from Manamla University and Aravind. He did his retina fellowship and is an excellent surgeon who is now practicing in Trichy from a family of ophthalmologists dedicated to eye care in Trichy. So we welcome you, sir. So over to you for your topic on ocular ultrasound principles and applications.
Good evening, everybody. So I'm going to talk to you over the next 20 minutes or half an hour about ocular ultrasound, its principles and applications. Applications meaning we'll basically look at specific case scenarios. So what is a ultrasound? Basically, it's a pulsed ecosystem. It has got three main components: a transducer, an amplifier, and a display monitor. An amplifier is just something which amplifies the signals which come from the transducer, and the display monitor is what you see. Either if it's an inbuilt machine, you might have a small LCD monitor inbuilt into it, or a lot of other ultrasound systems are connected to a computer, a Mac or a Windows, wherein they have a specific software where you can view the pictures. So how does this transducer function? This transducer is a main component of an ultrasound. How does this function? This is something similar to your speaker, wherein electric current, when it goes through the transducer, is converted as sound waves. The only difference here is it is converted into ultrasound waves. So because it's ultrasonic waves, you can't hear it. These ultrasound waves come off the transducer and it is passed into the tissue. Depending on a lot of factors like the frequency of the ultrasound waves and the density of the tissue and the interfaces, this is reflected off the surfaces. Depending on how late and how much the sound is reflected off each surface, an image is reconstructed. How? These waves are again picked up by the transducer and again converted to electric current. And once they are converted to electric current, it is then transposed into an image. So this is a basic thing about different ultrasounds. Basically, with ultrasound, like any wavelength, any electromagnetic radiation, this frequency is inversely proportional to the penetration. So abdominal ultrasound has got the lowest frequency, but it's got the highest penetration. Whereas an ultrasound biomicroscopy is got the maximum frequency of 50 megahertz or sometimes even 60 and has got the least penetration. Ophthalmic B scans generally are around the frequency of 8 to 10 megahertz. And I'm purposely skipping A scan here because it's not the purview of my topic. The two main things we should be worried about is the B scan and the UBM. The UBM was something very important some time back until OCT came in and it has replaced most of the clinical scenarios where we will be doing a UBM. But a B scan, which I told you works on around 10 megahertz, has a penetration of around 40 mm or 4 millimeters. That is why even if it's a highly myopic globe and you cannot get the ultrasound A scan going, you can still be able to measure the axial length using a B scan. The axial resolution of a B scan is around 940 microns. So to keep it simple, it is around 1 millimeter. So anything less than 1 millimeter, it is highly likely you will miss it on an ultrasound. The UBM with much higher frequency has got much poorer penetration. It does not penetrate more than 1 millimeter, meaning the maximum you'll be able to go up to is only up to the pars plana, not beyond that. But even that, with the OCT, now we are able to image almost up to the ciliary processes. Except for a few pars plana pathologies, UBM has become a little obsolete in the advent of OCT. However, the UBM is much more finer. The resolution is much more, and the resolution of UBM is around 40 microns. So there are four main things we should be worried about in ultrasound. First is the velocity of the sound used. Second is the reflectivity of what you're trying to study. Third is the angle of incidence, and fourth is the absorption. We'll take this one by one. Velocity of sound varies according to the medium in which it is traveling. Air is 330 meters per second. Water is much quicker, and aqueous and vitreous, being very similar to water, is little bit more. Cornea and lens is around 1641 milliseconds. It is in silicon oil, the velocity varies depending on the viscosity of the silicon oil. For example, 1000 centistroke silicon oil, the velocity is 980, whereas if it is more viscous, the velocity is slightly higher. That is why you need to correct for the velocity while doing a scan in a silicon oil filled eye. Metal has got the highest speed of sound inside the medium, which is around 5000 meters per second. Second is reflectivity, or the echo which you get once the sound bounces off the surface. This follows the law of acoustic impedance. Acoustic impedance means how much of sound the medium will allow to go through it and how much it will reflect back. This is a product of the density of the medium and the velocity of the sound. The velocity of the sound is only going to be same except when it keeps going further and further away from the probe. But depending on the tissue, as you can see in the slide, it varies. Bone being the most dense with almost more than 5 kilogram per centi square. And aqueous and vitreous, all these things, as I told you, is pretty much similar. The last two is the angle of incidence and the absorption. The angle of incidence meaning, if you look at this slide here, this is actually a retinal detachment. We all learn in ultrasound that retinal detachment is always high reflective. But you will realize retinal detachment is not uniformly high reflective. It is high reflective here. It is slightly moderately reflective. It is low reflective here. That is because of the angle of incidence. The sound has traveled directly and hit this portion of the retina, which is perpendicular to it. So that is high reflective. The choroid here is so much high reflective. Whereas these areas, which are oblique to the incidence of the sound, because a sound comes, most of the waves are going to be reflected in this direction rather than back to the probe. So these areas will appear low reflective. So it is not that a particular tissue or a particular medium is always going to be high reflective. The angle of incidence really matters. And the last one is absorption. How much gets absorbed? So this depends on a lot of other factors like the amount of interfaces in between. For example, if you take fat, which is not very different from the vitreous, it's only the impedance is not very different if you remember the previous slide. But fat, orbital fat has got multiple septae. So there is a lot of interfaces in between. So as you keep going deeper, the sound keeps getting absorbed in orbital fat as compared to the vitreous. If you all remember your ultrasound probe, most ultrasound probes will have a small white dot here, or some machines have a small white line also. Why is this line? Basically, an ultrasound is something like, one second, is something like a scan. Only thing, an A scan is just a single line scan, whereas an ultrasound is multiple line scans stacked on top of each other from the top to bottom. Imagine around 1000 and odd scans stacked from top to bottom. So each spike, each dot actually represents a spike in the ultrasound. So how do you know which portion of the eye this part of the image corresponds to? That is where this dot helps. Wherever this dot is, the top of the image corresponds to that part of the eye being scanned. There are three ways you can scan the eye. The first one is axial, second transverse, and longitudinal. This is a typical axial scan which runs through the cornea, anterior chamber, anterior and posterior lens capsule, and the posterior pole. So this is an axial scan. You can do an axial scan in a vertical or a horizontal or a oblique manner. The only problem in axial scan is you can only scan the posterior pole. And second, because you're passing through all the layers of the lens, the sound impedance is more. A lot of sound gets reflected off the lens, so your images are not that good. Second is a transverse scan. A transverse scan is something like when you keep your probe parallel to the limbus. Parallel to the limbus. This shows the orientation of the probes, these arrows. So when you keep your probe parallel to the limbus, you take anteroposterior sections of the fundus. Imagine there is a tumor and you want to see the lateral extent of the tumor, meaning from which clock arc to which clock arc it is extending. Then a transverse scan is the one which will tell you the extent of the tumor. Longitudinal scan, on the other hand, you hold the probe with a dot at the limbus, perpendicular to the limbus. You can hold it at any clock arc all around the eye, and this tells you the anteroposterior extent. So, for example, if this was a longitudinal scan with the probe positioned here, so you'll get a scan like this, wherein this will be the posterior mode part and this will be the sorry, this will be the posterior most part, this will be the anterior most part. So that's how the scans work. So whenever you do a scan, you should keep in mind on where the dot is, so that you know how the scan is oriented. So if you're picking up a very localized lesion, if you're picking up a total retinal detachment, it's a different thing. If you're picking up a localized mass, if you're picking up a retinal tear, you should know exactly which clock arc and how far under the periphery it is. So you should keep in mind your probe orientation. And in case you're saving an image, it's always a good idea to note down which probe orientation you used and in which clock arc or which place you used the probe. So this slide actually talks more about ultrasound, but this is something I wanted to share with everybody. This has helped me interpret imaging much better. Every imaging has got its own keyword. For example, in an X-ray, it's always radio. Any lesion on an X-ray is either radio opaque or radiolucent. Anything in an ultrasound is either hyper or hypoechogenic. It's echogenicity. If it's an FFA, you're talking of fluorescence, hyper and hypo. If it's CT scan, it's radiodensity, hyper radiodense, hyporadiodens. MRI is hyper and hypointense. You remember these 5 terms, you can literally interpret any imaging you're given. You need not really know what it is. You can always say there is a hyper radiodense area here and etc. etc. You can always, at least for the exams, that much should do. Next, we'll go on to the description of an ultrasound. There are 3 main factors with which you use to describe an ultrasound. First, when you see an echo, the shape of the echo. Is it a dot like what you see here? Or is it a line? Or is it a clump? A dot, a clump, and a line. Second is the echogenicity. Is it hypoechogenic or is it hyperechogenic? Is echogenicity, is it bright or is it dull? Third is a movement. Does it move or not? If it does move, then you have to characterize a movement, like is it freely mobile, or is it randomly mobile, or is it a tethered movement? We'll look into this later. First, we look at dot echoes. 4 main things, situations of dot echoes. First is asteroid halosis, then vitreous hemorrhage, endophthalmitis, and emulsified silicone oil. So I hope you're able to see this video clearly. Here you have a vitreous cavity filled with very high reflective echoes and a good amount of moderately reflective echoes as well. But what you will notice is there's a very clear dark area around the hyperreflective areas, hyperreflective echoes. This is a clear vitreous cortex. Such very high reflective echoes, all mostly concentrated in the center of the vitreous with a clear dark peripheral vitreous cortex, is always asteroid hyalosis. Incidentally, this person also has a small choroidal elevation and a choroidal mass, which you can see here in this area. That's an incidental finding. Vitreous hemorrhage can present in varied ways. Like for example, in this patient, there was absolutely no view of fundus because of a dispersed vitreous hemorrhage. But the B scan itself did not pick up that much echoes. This is because of fresh blood, which is fluid. Once the blood clots, it forms interfaces, which lead to more of clump echoes and more hyperreflective shadows. But this patient has got vitreous hemorrhage, but it doesn't appear dense on the B scan. But optically, this patient shouldn't have had a vision of more than 1/60. So one key point we need to remember is what is always acoustically clear need not be optically clear, and what is always optically opaque need not be acoustically opaque as well. This is another patient with a much more dense vitreous hemorrhage. You see a lot of blood clots, so there's more interfaces, so more hyperreflective clump echoes, and the posterior hyaloid is stuck in a couple of places. If you look at these lines here, this is a layering of the posterior hyaloid and a vitreous schisis, which means the posterior hyaloid is in multiple layers. This is something you'll have to take note while taking up this patient for surgery. You'll have to be aware that there'll be a second membrane or even a third membrane when you're operating. This is a patient following trauma. Actually, this patient had both vitreous hemorrhage and an infection. So to put it in a nutshell, just looking at a single picture of a B scan, it is almost always impossible to tell whether a patient has got a endophthalmitis or a vitreous hemorrhage. There are going to be echoes in the vitreous, and that's it. Based on a single picture, you cannot say. You have to have a video, and more importantly, you should know the clinical scenario before you interpret a B scan. The only ominous sign of a very severe endophthalmitis is a very optically quiet vitreous. This generally signifies there are no interfaces. Imagine a patient has come with a picture of panophthalmitis. You do a B scan, the vitreous looks abnormally quiet. Then invariably the vitreous is full of pus. Pus doesn't have any interfaces like an inflamed vitreous. So if the vitreous looks abnormally quiet in a very severe end of, which means you're in for serious trouble. This is a diabetic patient with vitreous hemorrhage. But more than the vitreous hemorrhage, what I want to note is the multiple attachments. There is one attachment here, another one here, another one here. Any membrane having multiple attachments all around in the globe cannot be a retinal detachment at all. It has to be a posterior vitreous detachment. If you look at the multiple attachments, the retina is attached only to the optic nerve and then to the ora serrata. Once it detaches, it cannot get reattached in any other place. So this is a typical incomplete PVD with multiple attachments, the focal tenting of traction retinal detachment. This is the last one. This is a patient who had a scleral buckle with a vitrectomy and silicone oil. This is post silicone oil removal. You will note these fine echoes dispersed all through and the slightly high reflective echoes. This is emulsified silicone oil remnants in the vitreous. This patient, if you examine him clinically, you might think the vitreous is actually clear, but still these patients will show small micro bubbles which are not even visible to your naked eye. So this is basically remnant emulsified oil. What you need to take note in this is the optic nerve shadow. You also see another shadow up here. This is a shadowing because and a slight indentation. This is a shadowing because of a scleral buckle placed in the periphery. Next, we move on to membrane echoes. So the most ominous thing we have bothered about is a retinal detachment. We've all read retinal detachment is a very high reflective echo, and it is tethered to both the ends of the optic nerve head, as you would see here. You would see that this patient also has a vitreous hemorrhage, a complete PVD, and then a retinal detachment. As I had shown to you earlier, a retinal detachment need not be uniformly high reflective throughout. It depends on the angle of incidence and other factors. The most important thing to note is the movement of the retinal detachment. The previous patient, if you had noted, the movement of the vitreous posterior vitreous was very free. Herein, if you see, there is movement, but the movement is sort of tethered. It's caught on both sides. So the movement is a tethered kind of a movement. This is a long-standing retinal detachment. The movement is even lesser. And this patient also has a large intraretinal cyst, two intraretinal cysts, one near the macula and one in the periphery. This is an extreme case of a closed funnel retinal detachment. This is a typical T membrane in the vitreous cavity. It looks like a T, wherein this is a short arm and this is a long arm. You would see the leaflets are closed, they've fused here and behind. There is a very small area of cleavage just behind the anterior aspect. So this is a closed funnel retinal detachment. This is another situation wherein you have a retinal detachment, but you also have an excavation of the choroid in the coats of the eye. So this patient has got a coloboma with a retinal detachment. So when you have a retinal detachment, you should also look at other things like how the movement is. If it is too stiff, then it means it indicates chronicity. You can look for subretinal echoes, which also means it's a chronic retinal detachment. You can look for other associated pathologies, like in case of injury, they might have a foreign coexisting foreign body, or it might be a coloboma with RD, etc. This is another form of retinal detachment. It's a stage 5 ROP. Very difficult to get a good image because it is not taken at a GA. The baby was alive and crying. So if you look at it, there's a stalk and there's a small loop inferiorly here. So that indicates the area of cleavage wherein you can start your surgery. This is very typically a neonate's eye because of the short axial length. There are two things I want to show you in this video. This is basically a complete PVD as opposed to that retinal detachment video I showed you earlier. If you look at the movements of the vitreous, they are very freely mobile. And second thing, it is not stuck to the optic nerve head anywhere. And second, these echoes are caused by the reverberations from the intraocular lens. Intraocular lens has got two parallel surfaces, and when sound hits the anterior surface, there's a reflection. It goes, hits the posterior surface, there's a sound reflection. This sound is not totally transmitted back through the anterior surface. Some of it is reflected back, goes, hits the posterior surface, again comes back, again goes back. So because of this, it causes an IOL reverberation. This will happen very commonly when you do an axial scan. So that is why in this scan, I had actually started off doing an axial scan and then realized there's so much reverberation. Then I've shifted my probe position to avoid the intraocular lens so as to get a good clear image of the posterior segment. And Ultrasound is useful to see things which you cannot see. This is a patient with a sudden onset vitreous hemorrhage. Careful ultrasound, if you notice this area here, the vitreous is detached all around, but it is still stuck here. And you see a small high reflective stalk projecting out here, this area, which is actually a retinal tab. This one. This is another patient with a vitreous hemorrhage, very mild vitreous hemorrhage. Did an ultrasound, realized he had a retinal detachment. You can even see the retinal tear. You can see the gap in the retina and the elevated flap here inferiorly. This is a patient with a complete PVD, but instead of blood being inside the vitreous, he's got a lot of subhyaloid hemorrhage. All the echoes predominantly are behind the hyaloid. And if you take note, if you look at his posterior hyaloid face, it is very high reflective. See that? This is because of blood staining of the posterior hyaloid. So you cannot mistake this as a retinal detachment because it is not attached anywhere to the optic nerve head. And there is a lot of subretinal echoes as well. Sorry, submembrane echoes as well. Next, we move on to a choroidal detachment. This person has a retinal detachment with a choroidal detachment. If you look at these dome-shaped elevations, which don't have any movement, if you had a concomitant A scan running here, you'll realize they have a what you call as a double spike, a M spike or a double spike, which is characteristic of a choroidal detachment. This is a primary retinal detachment with a concomitant choroidal detachment. The suprachoroidal space is visible here, which is clear. As opposed to this patient who had an expulsive hemorrhage intraoperatively, the whole eye is full of echoes. You see these dome-shaped elevations, but the suprachoroidal space in these cases is full of echoes, meaning it is full of blood. Ultrasound is very useful in these patients to follow for emulsification or liquefaction of this blood. When a significant amount of blood is liquefied, there are more darker areas, which is actually the right time to go in to evacuate these hemorrhagic suprachoroidal detachments. This is just a picture to show you. This is a choroidal detachment, clear suprachoroidal space, which means it's a serous suprachoroidal. This is a very hemorrhagic suprachoroidal with the suprachoroidal hemorrhage. You can already see few areas of clearing. Here the blood is dense. Here it is starting to clear. And both the domes are touching, which means it's a so-called kissing choroidals. Kissing choroidals always happen from the sides. They never happen from up and down. That is because of the vortex vein anatomy. The vortex vein is present at 1, 4, 7, and 10. So the distance between the 1 o'clock and the 4 o'clock vortex vein and the 7 o'clock and 10 o'clock vortex vein is much more compared to the vertical gap. The kissing choroidals always approach each other from the side and not from up and down. Next, we move on to intraocular calcification. Retinoblastoma is the most ominous intraocular calcification you can expect. So there's a large mass with very high reflective echoes. I will try to freeze in one frame. So if you see very high dome-shaped mass with a very high reflective echoes, and here if you keep going into the mass, you realize there is shadowing. This is because most of the sound is reflected from the calcium contained inside the mass. So the penetration in that area alone is lesser compared to the other areas. There is a congenital anomaly, an optic nerve head drusen, very small high reflective echo at the optic nerve head itself. I have taken this picture in a full gain. If you reduce the gain so that you barely see sclera, still this high reflective area will persist. That means this optic nerve head drusen. Very important, especially when you suspect very subtle papilledema, to do a B scan to rule out a buried optic nerve head drusen. Another congenital malformation, a choroidal osteoma. It's a plaque-shaped classification of the choroidal layers. If you notice, the more or less the anatomy is normal, except in this area it's very high reflective, very intense shadowing behind the lesion, meaning there is calcium here which is reflecting most of the sound and not letting it penetrate any further. This is another situation of plaque-like calcification, but this is not difficult to easy to miss because it is basically a Thyssenkrupp eye. It's a very deformed eye with multiple irregular plaques of calcification, which is basically the scleral coats which have undergone dystrophic calcification. This is an iatrogenic issue. it is basically a silicone oil filled eye. A lot of times, even clinically, sometimes you're really doubtful whether there's still silicone oil in the eye. Patient operated elsewhere, you don't know. You'll find a very long, elongated globe here. And this person already has started getting emulsification. So you can find a few emulsified bubbles inside the oil as well. The eye looks abnormally long. The posterior pole is very flattened. Sometimes if the eye is already highly myopic, this posterior globe itself may not come within this range of the scan. In that case, you have an orbital mode for in the ultrasound machine, wherein you can go to the orbital mode, wherein the depth becomes more and this posterior sclera is visible here. So if you have silicone oil and not able to visualize a posterior pole, you should always go into the orbital mode. This is a dislocated nucleus of a patient who underwent cataract surgery. You can see a few vitreous echoes, probably because of the loose cortex floating in the vitreous. And this is the nucleus in the inferior vitreous cavity. If you look at it, there are high reflective echoes in the front and back, meaning this is the poles of the nucleus from which the sound is reflected. But what you need to take note is the interior of the lens is relatively clear. It's probably had a little bit of trenching or chopping done, so it is not very regular on this side, whereas this side is regular. But the interior of the lens is not very hyperechogenic. Why? Because if the cataract becomes harder, the interior of the lens also becomes very high reflective like this. So before, if the view is not good, you have a nucleus drop in hand, you want to know how hard the nucleus was, you can always do a B scan and see whether the nucleus was a very hard nucleus or it was not that bad. And more importantly, associated pathology. This person has a very thick sheet of cortex sitting in his pupillary area, not able to see fundus. But before you take him up, if I had not done this B scan, I wouldn't have picked up this coexistent retinal detachment also this person had, along with the nucleus drop. This is nanophthalmos, a very short eye, usually less than 20.5 millimeters in length. If you look at it, the lens size is relatively normal. The axial length is very, very short. And if you look at the retinochoroidal scleral thickness here, it is very, very thick. It will be almost 3 millimeters and more. If you keenly look at it, I'm sorry, I cannot do a zoom here, but zoom meaning I cannot zoom the picture here. So this is the retina, the choroid, and the sclera. This gap is the junction between the sclera and the orbital fat. The first high reflective echo which comes here is actually the first layer of orbital fat. A lot of times this is mistaken to be the sclera. No, this is the sclera, and this first high reflective area is the orbital fat. Foreign body, there's something wrong in my video, so I just picked up a couple of stills. Pretty obvious, very high reflective echoes with post-echo shadowing. And you'll always find a lot of reverberations if the foreign body has got even edges, or if it's a BB, which means it's a circular in shape. Two problems with foreign bodies, as I told you, because of the resolution of ultrasound, anything less than 1 millimeter in size, you will not be able to pick up that easily. It's very easy to miss. And second being, if it is very anterior, also ultrasound is not that great a tool to pick up an intraocular foreign body. And a lot of times these persons, if they come early, then they have an open globe, and pressing and manipulating an open globe is not that good idea, because you'll be causing more damage. So intraocular foreign body, yes, you can use ultrasound to find out the intraocular foreign body, but I would always prefer a CT scan to know exactly where the foreign body is and to rule out any other smaller foreign bodies anywhere else in the eye. This is posterior scleritis. It's a thickening of the retinochoroidal complex. If you look at this area is thin, whereas this area is a very thick sclera with a small separation of the tenon space. So this is my last slide. It's a very interesting patient, really. Patient had a mature cataract, no history of trauma, nothing. And this is what I found on B scan. Found a very high reflective circular echo. I'll freeze that frame for you. Give me a minute. So a nice high reflective echo, something round. I don't know what it was. I asked for all sorts of history for trauma. Maybe it's a foreign body. Then I thought maybe it's a small cystic cyst. But then I wasn't too sure. So they took up the patient for a combined cataract with vitreous surgery, maybe thinking that might be something we need to take out. After the cataract surgery, I examined the fundus. I couldn't find anything except a posterior vitreous detachment. So this was just a vitreous echo, which was vitreous opacity, which was giving such an echo. So the take home point of this last video is what you see on indirect need not necessarily be picked up on a ultrasound B scan, as I told you earlier. For example, if a person has a vitrectomy and has a dispersed vitreous hemorrhage, you'll hardly find anything on a B scan. It'll all be dark because it's just water with a little bit of blood mixed in it, which means there is no interfaces. So there won't be any shadows here. But at the same time, something like this might look very ominous and obvious on a B scan, but when you look at the patient clinically, a lot of times you don't find anything. So the best way to actually learn to interpret B scan finding is whenever you can see a finding in the fundus, you do a B scan and then learn how that finding actually looks on a B scan. That is the best way you can actually learn to interpret any finding which you see when you actually don't have a view of the fundus. So final message to all, stay at home, stay safe, and this too shall pass. Thanks to Dr. Venkatesh and the team at Arvindai Hospital for giving me this opportunity. And I should mention my mentor in ultrasound, Dr. Muna Bende, without whom all this wouldn't have been possible. Thank you.
So thank you very much, sir, for the excellent lecture with the videos of B-scan. So we are now open to questions. You can just unmute your mics and ask your questions orally.
Either I've been too clear or I've been too confusing.
Hello, sir. Good evening.
Good evening, madam.
Sir, I'm Dr. Ma. Sir, one doubt is like intraocular foreign body. If there is any intraocular foreign body, how high density spike is seen. But in some cases of suturing also, if you find that
your audio is not very clear. So could you be a little slow?
Yeah, sure, sir. In case of any suture material is there in cornea, after corneal wound suturing, sometimes we find a hidden sequogene spike in vitreous. That is shadowing. How to differentiate intraocular foreign body with this?
I still can't get your question. You're asking me how to differentiate a spike from a corneal suture versus an intraocular foreign body.
Yes, exactly. Yes, sir. Yes.
See, first thing, a corneal suture, it will not be picked up that well on a ultrasound B scan because it's too anterior. Anything in the anterior segment, usually if imagine you have an anterior segment foreign body in the anterior chamber angle, it's very difficult to pick it up on ultrasound because it's too close to the probe. All these probes have something called as an acoustic window. Basically, because the earliest echoes, if they start getting received and amplified, they'll cause too much of artifacts. The initial few millimeters, actually the echoes are suppressed. So that is why you do a standoff wherein you put a small glove filled with water or a small ball or something, and then you put a lot of gel on the eye so that your probe comes further from the eye to image the anterior part of the globe. So as corneal suture is very, very unlikely it will produce, you'll be able to pick it up. And second, most important, where you find that echo. A corneal suture, even if you do pick it up, it will only be an after shadow which you pick up. Whereas if there's a foreign body in the vitreous, you will see that foreign body floating in the vitreous. It won't be, the reverberations will not be in front of it, will only be behind that. So you'll see the foreign body and then see the reverberations behind that. So the position of the primary echo matters.
No, but still, sir, in number of cases I am seeing after corneal wound suturing is there. In the X-ray or CT, there is no intraocular foreign body, but on B scan, there is a high density spike.
That is why I said a CT is much more reliable in these cases compared to a B scan.
So we should advise CT in all these cases.
I think both clinically and medical legally, you are expected to do at least an X-ray, if not a CT scan. Medical legally, certainly the courts accept an X-ray more than a B scan, which I don't accept.
In wooden foreign body, sir. Like in wooden foreign body.
In any patient with penetrating trauma.
Okay.
Any patient with penetrating trauma. It need not matter whether there's a high risk of foreign body or not. Even if you don't think there is a foreign body, I would always do at least an X-ray. Well, nowadays CT scan doesn't cost much, and the attitude for us is more to save our skins first. So always better do a CT scan and then proceed. Or worst case scenario, if you sutured without doing any imaging, do it the next day. And once there is no foreign body, you can rest in peace.
Okay, so thank you.
Because whatever is too anterior will not be picked up in a B scan, and something which is very small also will not be picked up in a B scan. The only problem with the CT scan is organic material. Say small wooden splinter, if the wooden splinter imbibes enough water to have the same reflectivity of the same radio density of the vitreous, it may not be picked up. That is the only negative point of a CT scan.
Okay, so thank you, sir. Thank you so much.
Welcome.
There are a few questions in our chat screen. So
I'll
they
go
are
through them.
asking, are there, yes, sir, any specific signs of endophthalmitis?
Yeah, what are the signs of endophthalmitis in B scan? See, if somebody can look at a simple frozen 2D image and tell you if it's a endophthalmitis or a vitreous hemorrhage, that person is most likely lying, because both of them look pretty much similar. It is just echoes inside the vitreous cavity. Uh, Only thing, there'll be certain other signs in endophthalmitis which you may not find in a vitreous hemorrhage. You'll find a lot of membrane echoes, not only dot echoes, also membrane echoes. And if the inflammation is very severe, and the patient is progressing to panophthalmitis, you might start seeing tenon space widening or your classical T sign if it becomes very severe. So these additional factors are going to support the diagnosis of endophthalmitis. But otherwise, if you just show me a vitreous cavity filled with echoes and ask me whether it's endophthalmitis or a vitreous hemorrhage, I don't think anybody can actually say that. You have to take the clinical scenario into consideration. And if there are other signs, like let's say a T sign or a lot of membrane echoes, then you can conclude, yeah, this is a endophthalmitis or it is a vitreous hemorrhage. Next is, how do you explain the gain of B scan? Where should we use high gain? See, gain is basically the amplification. It is like your volume control on your stereo. If you can't hear something well, you turn the knob up. If you can hear it well, if it's too loud, you turn it down. The same way, if you think you cannot pick up echoes, you think that this patient has got vitreous hemorrhage, you're not very sure, there may be a faint vitreous hemorrhage, that time you turn the gain up to pick up even slight echoes. But remember, even a normal, absolutely normal 6'6" patient walking in, you do a B scan for him, you'll realize he might have a few vitreous opacities on B scan. So how do you differentiate this normal vitreous opacity from a pathological one? It is actually very difficult, almost impossible. The simplest way to get around this is, let us say one patient comes, one eye has a mature cataract, you do a B scan, there are a few echoes in the vitreous. You don't know whether this is actually a mature cataract with vitheme or just a mature cataract with a clear vitreous. Simplest way is to do a B scan of the other eye. If the other, wherein you can see the fundus, if you can see the other eye fundus, vitreous is clear, and that vitreous also has got similar echoes, you can conclude most probably this vitreous is also echo free. The other thing is reducing the gain. You should reduce the gain to see things which are very highly reflective. For example, the optic nerve head drusen. Or let us say there's a person with the penetrating injury with a lot of vitreous hemorrhage. You're not sure whether there's an intraocular foreign body. There are so many echoes all over. You reduce the gain, most of the echoes because of the vitreous hemorrhage will disappear, while the echo because of the intraocular foreign body will persist because it is very highly reflective. I hope I answered that question. What are your gain settings for different pathologies? That's pretty much the previous question. It depends on the type of pathology. So if you're looking at something which is not very highly reflective and you're finding it difficult to pick it up, you have to increase the gain. If it is something which is already high reflective, you want to differentiate a high reflective from a very high reflective pathology, that time you have to reduce your gain as much as possible to pick up that very highly reflective lesion. How do you differentiate between air bubble and intraocular foreign body? Sorry, actually, I should have had a B scan of an air bubble. An air bubble doesn't let sound pass through it at all. Once the ultrasound energy hits the air bubble, most of it is reflected. So you'll hardly see anything beyond that. And you'll also see a lot of reverberation echoes. And it is not very highly reflective like an intraocular foreign body. So, and the second thing is motility and the place where the echo is. An intraocular foreign body can be anywhere inside your eye. It can be inferior, temporal, anywhere. An air bubble will always be in the superior aspect because it always only floats up. How to diagnose endophthalmitis differentiation from vitreous hemorrhage? I've already answered that. Gain settings was a previous question. Where can we use orbital mode? Well, you can use, other than the silicone oil filled eye, if the eye is very, very myopic and you're not able to visualize posterior pole, you can use orbital mode. But usually the B scans have a depth penetration of 4 mm. So it's in a normal eye which is not filled with silicone oil. It's very, very unlikely that you won't be able to visualize a posterior pole. So in those cases, normal mode should do. But sometimes to measure axial length, you may have to go into orbital mode. Other than that, the only other thing we have to do is go for an orbital ultrasound. Again, as I said, I don't think any orbital surgeon is going to rely on your findings, ultrasound findings of the orbit or your extraocular muscle thickness. They're always going to go ask for a CT or an MRI. So even though we used to do orbital mode ultrasounds and look at tendon sparing, thickness, thickening, and etc., I don't think it's hardly done these days because of easy access to a CT scan. What is the most common angle used for doing B-scan? I think you missed my initial few slides. There are three ways you can do it: an axial, transverse, and longitudinal. So there are three different orientations. An axial can be done vertically and horizontally, and transverse can be done in 9 different ways, and longitudinal can be done in 12 clock hours. So that was in the talk itself. How sensitive is B-scan to ONH cupping? See, ONH cupping is very, very misleading. I have had patients where, because mainly it depends on the size of the optic disc. So the last week, one of the lectures was about how the cup to the disc size, the cup ONH cup size to cup ratio to the disc size. So if you're going to have a very large disc with a physiological cup itself, which is around 0.5, 0.6, that might be picked up. That might be picked up as optic nerve cupping. Whereas if you have a person with a very small disc and a 0.8 cup, probably that is not going to be picked up at all. So B-scan itself, you can suspect optic nerve cupping, but you cannot really conclude that it is optic nerve cupping based on a B-scan alone. Anterior chamber angle analysis, UBM or anterior segment OCT. Any day anterior segment OCT because of easy access. UBM, more places have got anterior segment OCT compared to a UBM. And second, anterior segment OCT is non-contact, and the resolution is much, much better than a UBM. Can we locate extraocular muscles over sclera on a B-scan? If yes, what are the settings? Well, first you have to go into orbital mode, and then you'll have to do a longitudinal scans. You have to do longitudinal scans to track the extraocular muscle going up to the attachments. As I said, a CT is much more reliable here compared to a B-scan. If you use A-scan with B-scan, can we be able to most precise do a B-scan alone? No, not really. Because why you cannot rely more on a B-scan than a A-scan? You're saying you want to make it more precise. More precise meaning you're assuming your B-scan measurement of axial length is going to be more accurate compared to A-scan. I'm sorry, it cannot be done that way for the simple reason, because if you try measuring a B-scan, you have to place the marker points. You have to place where the posterior pole is. You have to locate the anterior surface of the cornea and place your pointer there, and then it measures between these 2 points. So it is very much subjective. So you can always, a little bit here and there, you can always make a mistake. The way a B-scan can be helpful while doing an A-scan is in a highly myopic patient with or without silicone oil, wherein you get a very varied A-scan values, like you get 31, 33, etc., etc. You can at least do a axial B-scan and see approximately what is the axial length. You can say, okay, is it really around 33 or is it really around 35? That is what you can do. You cannot exactly say, okay, my B-scan measurement is 33.53, so this is my axial length. No, you cannot conclude like that. But you can arrive at a ballpark figure. How to read or document staphyloma and coloboma? Read or document is, see, a staphyloma, I didn't have a picture, but a staphyloma will be a more oblong or egg-shaped outpouching of the posterior pole, whereas a coloboma will have sharp edges. I did show you a video of a coloboma. That is how we differentiate between a staphyloma and a coloboma.
Sir, I have a doubt, sir.
Yes, sir, please.
Sir, in a situation of like a medical oncologist or someone refers to us with a unilateral vitreous hemorrhage for a
Yeah.
patient was already treated and under remission for some other systemic cancer.
Okay.
And if you come across a unilateral vitreous hemorrhage, and when you do a B scan, you get something like a choroidal thickening. So, sir, how can, if you want to confirm it as a secondary spread or choroidal or mets, actually,
You're not able to see the fundus.
if we are not able to see in a picture of a vitreous hemorrhage, and when you do a B scan, accidentally you are seeing a choroidal.
So because, okay, I'll
It's
answer
how can you reply to oncologist saying that you have to definitely.
So first and foremost, you should, let me go step by step. As I told you, B-scan is not a great tool on its own. You have to look at the patient clinically.
Yes, sir.
First thing, you'll have to ensure that patient only has a vitreous hemorrhage. It can very easily be vitreous seeds. It can be vitritis because of cells, especially in case of large cell lymphoma of the CNS. It's a very, very common presentation. So first thing, you need to make sure it's a vitreous hemorrhage and it is not any other infiltration of the vitreous by cells other than RBCs. So that's the first thing. Let us assume, yes, he has only vitreous hemorrhage. you do a B scan. Again, there are two things you're talking about. One is a METS. A choroidal METS doesn't present as a uniform thickening of the choroid. It presents as localized lesions, pretty much like a melanoma. So the differentiation of a melanoma and a choroidal METS is also there, but that is possible only when the tumor is beyond a certain size. Second thing is coexistent other pathology. Choroidal METS a lot of times have a retinal detachment. The simplest way to differentiate a melanoma from a choroidal METS is a melanoma will be a very large tumor with a very small retinal detachment surrounding the tumor, whereas a choroidal METS will be a very small tumor with a disproportionately large exudative retinal detachment associated with it. And then the last thing which you asked about, diffuse choroidal infiltration. Yes, you can, if it goes beyond a limit, you can measure the choroid and say, yes, the choroid is uniformly thickened or localizedly thickened. Again, the cutoff is not very, very definite. It is not that if anything more than 2 mm is 2.1 is choroidal thickening because of infiltration. There's no definite cutoff. But if it's very gross and obvious, you can pick up. There are two ways a choroid can thicken. It can thicken because of imbibing fluid, or it can thicken because of cellular infiltration. If it thickens because of cellular infiltration, like in the case of inflammation or in the case of malignancies like a large cell lymphoma, then the choroid will become thickened, and it will also have high internal reflectivity because of the cellular infiltration. There is numerous interfaces, so it will be high reflective. Whereas the choroid is edematous, or it is, let us say, like nanophthalmos, it will be uniformly reflective. It will not be very high reflective. Internal reflectivity of the choroid will not increase if there is no cellular infiltration. Okay.
So there's no way to confirm that it probably will be the secondary to the tumor, or
See, yeah, that's what I'm saying. If there is a definite mass,
okay.
yes, you can say it is a secondary. You're talking about not having a mass. You're talking about an eye having eye full of blood. You're talking about suspicious choroidal thickening, correct?
Yeah, yes, sir. Yes, sir. Suspicious
So
way.
suspicious choroidal thickening. Suspicious will remain suspicious only.
Okay.
Unfortunately, see, when it goes beyond an extent, yes, you can find out. But when you're really doubtful whether is the choroid thickened or not, only standard you have is to compare with the other eye. Let us say you compare with the other eye, and the other eye choroid is very, very thin, and this eye choroid is thick, and that may give you a clue to conclude, yes, the choroid is infiltrated. You understand what I'm talking about? Because
yes, sir.
when you measure choroid also, like I spoke about measuring the axial length of the eye, while measuring choroid also, there is a lot of subjective error. So you cannot really say, okay, if he's got 1.9, he is normal. If he's got 2.1, the choroid is thickened. It doesn't work like this. There's no single point cutoff. Because choroidal thickness itself is highly variable between people, depending on a lot of factors, mainly being the axial length of the eye. And myopic eye, and we're not only measuring choroid here, remember that. If the retina is attached, you cannot measure the choroid separately. You are measuring is retinochoroidoscleral thickness. So a highly myopic eye will have a very thin choroid.
Yes.
If he has some amount of infiltration also, you will not think it is choroidal thickening until it reaches a particular limit. Whereas a highly hypermetropic eye will already have a very thick sclera and a thick RCS complex. So even a slight increase in thickness, you might interpret it as a choroidal thickening. So there's a gray area in between, but either side of the gray area, yes, if the RCS thickening is absolutely normal, there is no high reflectivity of the RCS areas, and there is no definite mass lesion, there is no exudative retinal detachment, you can conclude maybe this is only a vitreous hemorrhage. And the next thing, if you're still not very clear, the next thing we need to do a vitreous biopsy and study what type of cells are there inside the vitreous. That will give you a better clue. And most importantly, it also depends on what type of primary it was. See, if most of the primaries which come through blood cause mass lesions, they don't cause diffuse infiltration. It is only CNS lymphomas which cause diffuse infiltration. So first thing you should be actually knowing about is what type of primary tumor the patient had. Hope that answers your question.
Okay, sir. Thank you, sir. Thanks a lot.
What primary did the patient have actually?
Actually, it was my brother-in-law asked actually for a eye consultation. So,
Okay.
like the tumor was stomach cancer. So
it's more likely to be a bloodborne spread. So if you don't find any mass lesion whatsoever,
okay,
then more or less you are clear.
okay. Sure, sir. Thank you, sir. Yeah.
Thank you. We'll go to the next question on my chat window. Generally, the gain is 70. What is your default setting? How do you measure optic disc for 0 point miss? Okay, first I'll answer the first part of the question. The gain generally depends on the machine. In my machine, which is an OTI B scan, I usually keep it around 75 to 80 because that picks up most of the findings. As I told you before, if you keep a very high gain, even a normal vitreous, you will start picking up findings. And if you keep it too low, even a mild early vitreous hemorrhage you might miss. So 70 is acceptable, 70 to 80 is acceptable. It's an average. So always start off. Depending on what you see, you should increase your. It's not that you just put. It's like asking me what speed do you drive your car in. I'll drive my car in the speed which the road allows me and what I want to do. So depending on what you see inside, you have to change your gain settings. That is more important. How do you measure optic disc for 0.9 disc or pale disc with mature cataract? A totally contradictory question, because if the cataract is mature, I don't know how you found the disc to be pale and the disc to have 0.9. As I told you, you can pick up optic nerve, you can pick up the cup on a B scan. But is it a 0.9 cup? How significant is it? It is very, very difficult to say. I have pictures of patients with normal optic nerve heads showing optic nerve head cupping on B scan, and patients with total glaucomatous optic atrophy where the optic nerve head looks normal. If you email me, I will send you those pictures also. So it is very difficult when you have no view of the fundus to absolutely say whether it's a 0.8 or a 0.9 cup. That is impossible. Next one is how reliable is a B scan to diagnose recurrent RD in silicone oil filled eye? Why is that R there? How reliable is the B scan to diagnose recurrent RD in silicone oil filled eye? Any tips to figure this out? See, the problem with silicone oil is, first thing, it flattens the posterior pole, the posterior aspect of the globe. So it's very difficult to find out. Second thing is, the silicone oil's posterior surface is very highly reflective. And third, most of the superior 3/4, half or even 3/4 of the eye, the oil is pressing on the globe. So if doing the B scan in a sitting up posture especially, most of those places, the elevation of the retina will be very, very subtle. Where you can find a definite retinal detachment under silicone oil is if the detachment is inferior. That is the only place you can find out. But other than that, finding out a retinal detachment under a silicone oil, a very, very shallow detachment, is very, very difficult. Next one, differentiating exudative RD from reg RD. Well, reg RD, first thing you have to look at it clinically. The most important way of differentiating an exudative RD from a reg RD is shifting fluid, meaning the fluid shifts. The regmatogenous RD can also have shifting fluid, but the key point in differentiating an exudative retinal detachment and reg RD based on shifting fluid is, a reg RD, imagine there is 3/4 of the retina is detached, the superior 1/4 is attached. When he's sitting up, he'll have large inferior bullae. You make him lie down, the inferior bullae will go down. The macula, which was which had a shallow detachment, might become more detached. But still, the margins of the retinal detachment will not change, meaning whatever was attached when he was sitting up will continue to be attached even when he's lying down. Whereas in an exudative RD, that is not the case. If he's sitting up, the superior retina will be attached, inferior will be bullous detached. When he's lying down, the inferior bullous detachment will come down and the superior attached retina, which was the superior retina attached previously, will detach. So that is the true shifting fluid of exudative RD. In a regmatogenous RD, the fluid shifts, but only within the boundaries of the detachment. In an exudative RD, the boundary of the detachment itself will change. So that is how you actually have to make the patient sit up, do a scan, make him lie down, not immediately, wait for a few minutes, at least 3 to 5 minutes, and then do a B scan again in lying down posture. And then compare both the images and see whether the margins or the extent of the retinal detachment is changed. If it is changed, it has to be an exudative detachment. Besides, you might find a retinal tear if it is a regmatogenous detachment. If it's an exudative RD, if it's because of a mass lesion, you might find a mass lesion. If it's because of a condition like VKH syndrome, you will find a choroidal thickening. So that's how, but shifting fluid is the most important point. Procedure to measure EOM thickness, that's a separate thing by itself. You basically have to do a longitudinal scan. If you want to image medial rectus, you have to keep it temporally, trace it up to the insertion, and then measure it. As I told you, CT scan is a much better and more reliable tool to measure EOM thickness. Can we use a vaginal probe which has 12 megahertz? Yes, you can use. If you don't have access to a B scan, better than using a vaginal probe, I would say there is something which all these general B scans are. They call it a small parts probe. You use it to measure this thing, look at your finger and all those things. So that small parts probe is much more useful than a vaginal probe. Because a vaginal probe, if you look at the probe between a normal eye ultrasound B scan probe and vaginal probe, the B scan probe has got a flat front. The vaginal probe will have a circular front because they want the sound to go on all sides. They want to look at the uterine cervix and the paramaterial spaces and all. So that is different. Where a small parts probe will be flat. A small parts probe is more useful. The other problem you will have is the image won't be oriented sideways. It will be oriented top down. The initial Apasami machines, the image will initially be oriented top down. Then there's a particular button which we click, it will actually then get oriented sideways because they had worked on a general ultrasound and then made it into an ocular ultrasound. So that's another problem. The third problem is, which I face in most of these using these general B scans for ocular ultrasound, is the resolution. The resolution is never this good. That is because of the acoustic window. Our acoustic windows are different from their acoustic, the inbuilt acoustic. These things are inbuilt. I can't go and change it. So these acoustic windows are different in an ultrasound, which is meant for the eye, then compared to an ultrasound, which is meant for the other parts of the body. So yes, if you're going to ask me, I have a mature cataract, I don't have access to B scan. Can I send him to my local sonologist to find out whether the retina is attached? Yes, you can do. It will certainly tell you whether a retina is attached or detached. But if you're going to ask me, there's a very shallow membrane echo. Is it a PVD? Is it an RD? Differentiating that will be difficult. But for a mature cataract to just say, yes, posterior segment is acoustically clear, retina is attached. These are the only two information you want. Then you can very well use a vaginal probe or any other probe to just, you can just send it to your sonologist, he'll do a scan and send it back to you. Simple. Slide illustration of the probe orientation and positioning wasn't clear. Just remind me when I finish all the questions, I will go back to that slide. Can you show choroidal melanoma and choroidal hemangioma B scan picture? I don't have both of them side by side, madam. I'm sorry. How do you measure choroidal thickness? I will have to share my own screen. It's different on each machine. If you open your B scan machine, you should first reduce the gain so that you see the retinochoroidal scleral complex clearly. If you want, a lot of machines have a zoom function. You can use a zoom function to zoom on the retinochoroidal scleral complex alone. Then you will have a caliper tool on your B scan, which you should open, and you should ideally do it at the macula, do it at the first high reflective echo, which is the retina, and then go up to the last low reflective echo, the area just in front of the orbital fat. So that gives you a measure of the choroidal thickness meaning the RCS thickness. Why is a M spike seen on a CD? A M spike is seen on a CD because of the reflection from the retina and the choroid. There are two reflections. The first spike is from the retina, the second is from the choroid. What are the limitations of B scan? Limitations, I don't know. It's a very, very general question. I think I've told you a lot. Throughout my talk, I've told you a lot of limitations with respect to foreign body. I've told you how it is not very accurate. With respect to orbital B scans, I've told you how CT scan is better. And the most important thing, which I've already stressed and I'm again stressing, is what is optically clear need not be acoustically clear. What is optically opaque need not be acoustically opaque. I'll give you two very clear examples. You might find somebody with, like my last video I showed you, with a lot of echoes in the vitreous on a B scan. You examine that patient and probably he won't even complain of floaters. It will be a very long-standing PVD, and all the ultrasound needs to have an echo is interface which will reflect sound. The interface which reflects the sound need not really reflect light. That is a basic idea. If it reflects light, you will see it. The more it reflects light, the more you will see it. The more it reflects sound, ultrasound will pick it up. Opposed to the other situation, imagine a patient who had a vitrectomy with a very small bleed in the vitreous cavity. Vitreous cavity is full of aqueous. It is like just a glass of water with one drop of ink. One drop of blood is enough to blur the vitreous cavity and bring the patient down to hand movements vision. You won't be able to make out anything in the fundus. You do a B scan, you'll hardly find anything on a B scan. The whole vitreous will be dark because there are no interfaces. So the moment there are no interfaces, B scan doesn't pick anything up. But because there is blood mixed in the aqueous fluid in the vitreous cavity, you're not able to see the retina. This is the limitation of the B scan. Cutoff is around 2 to 2.5 mm. For the RCS complex thickness, Aditi, the cutoff beyond which RCS is 2 to 2.5 mm. As I told you, there's no definite single number you can quote. Anything less than 2, I would take as normal. Anything more than 2.5, or if certainly more than 3, I will take it as abnormal.
Thank you, sir. Is there any other questions from the other places?
Have any other questions which are related to this also, I'm happy to answer. I don't have an issue. I'll try going back to that slide. This is somebody was asking me about probe positions. See, three main positions: axial, transverse, and longitudinal. This dot corresponds to the top of the picture. So anything passing through both the surfaces of the lens and going and hitting posterior pole is an axial scan. So you can hold it horizontally, wherein you'll cut the posterior pole like this, or you can hold it vertically. So axial scan goes through all the layers of the lens, and you can hold it either horizontally or vertically. If you hold it vertically, obviously dot will be on top. When you hold it horizontally, convention is that the dot should be oriented towards the nose. The next one is a transverse scan. See, if you only place it parallel to the limbus, I will show you this. Imagine I want to see from this point to this point. I want to image it like this. It's very difficult to show it to you on a 2D image, but when you want to look at the transverse extent of a lesion, you do a transverse scan. When you want to look at the anteroposterior, from here let us say from the ora serrato to the optic disc, you want to see how far a particular lesion extends. Then you do a longitudinal scan. I didn't put too many arrows because it will make it more messy. You can have a transverse vertical, you can have a transverse horizontal superior, inferior, you can have one arrow here, one arrow here, two horizontal arrows, and if you any textbook will have these pictures, and oblique transverse also. Longitudinal, imagine this is 12 o'clock, 3 o'clock, 6 o'clock, 9, like that. From 1 to 12, any clock hour you can do a longitudinal scan. One more question. Okay, so thank you, message.
So thank you very much, sir. There seems to be no other questions. It was an excellent presentation with the B-scan videos and all. So looking forward to more lectures with you hereafter.
Thank you. Thank you so much.